7D, Health Department.
Okay, for the Health Department, we had two new positions in the recommended budget. That one was the Public Health Nurse 2. That was for a wages and fringes total of $80,796. And then we had two Vision and Hearing Techs for combined cost. Those are part-time positions for a combined cost of $36,945. Both positions are fully funded by grants or projected charges for services related to the positions. The general fund expenditures were up 2.8% since 2017 amended, total of $580,647 in increases. The significant increases are from supplies and services and contract services. For supplies and services, that was mainly the result of vaccines and medical supplies. The vaccines were recommended to go up by $80,000, medical supplies by $24,000. Indirect costs also increased by $300,000, mainly as a result of building charges and IT charges associated with those. Those are outlined in our cost allocation plan that's done annually, so there's an uptick there. The general fund revenues related to the health department is coming in at $7,404,040. That's up 3.2%, or $231,349 from 2017 amended. And then the significant changes there are charges for services in the amount of about $180,000, mainly as a result of rate increases for $40,000, and then about $110,000 in Medicare or Medicaid insurance increases based off the number of population projected to be served in 2018.
Very good.
With that,
Thank you very much. I'm sure you're going to be back.
Thanks, Steve, and with that, I'll take any questions. No,
Oh, yeah.
pretty comprehensive. He stole all my thunder, but again, good afternoon. And before I begin, I just want to introduce some of our staff that are here from the Health Department that you may or may not have met. Crystal Willett, our Deputy Health Officer, is here. Dr. Kevin Lokar, who is our Veteran Medical Director for the Health Department, is here. Patrick DeTine is our Finance Manager. And also, Dr. Daniel Spitz, our Chief Medical Examiner, is here, and you'll hear from him a little bit after I'm done to talk a little bit about the Medical Examiner's Office. And Patricia Rowland, our Operations Manager in our Medical Examiner Office. So again, good afternoon. We did bring copies of our annual report for the Health Department, as well as the annual report for the Medical Examiner's Office, which Dr. Spitz will talk a little bit about in his presentation after mine. Just want to report on some of the things we've done this year from the budget you approved at this time last year, which I think are pretty important. One of those is in the area of maternal and child health, an area that we implemented a new program in Macomb County called the Nurse Family Partnership. This is a home visitation program for first-time moms, where the public health nurse spends time from early in pregnancy through the first 2 years of the infant or child's life. It's an evidence-based program with very effective and documented outcomes, and we implemented that program. I have a manager and clerical staff and a couple nurses on board, and we're looking to hire another nurse to complete this program, so we'll be off and running, and then we're really happy to get that off the ground. Secondly, our dental clinic. We transitioned our dental clinic over to My Community Dental Centers. They took over the clinic at the beginning of the year, did some major renovations at our Southwest office, added a 4th dental chair, and are providing services 5 days a week for all residents in the county. The focus is on, of course, uninsured and Medicaid, and they're doing an excellent job. They are partnered with another 15 other health departments around the state, and we're very happy that they're on board and providing quality services for residents that seek dental care at our Southwest office on Van Dyke and Martin Road. And lastly, in April, we had our, not annual, every 3 years we get an accreditation visit from the state of Michigan. And this year we had the 3rd or 4th week of April, the state had reviewers come down and review the administration and a number of our programs. And I'm happy to report that of the 159 indicators that we had to meet, we met every one of them. First time we've done this since the program began in 2000, and we're very happy to have been accredited with commendation from the state of Michigan as a local health department. Our ultimate goal is to be a nationally accredited health department, which is one of the objectives that we have set forth as a health department, to be one of continuous quality improvement and accountability to the stakeholders of the funds we receive from not just the county but the state to provide public health services and wellness in Macomb County. This year's budget for 2018, we are very satisfied with the recommended budget. We believe this budget will allow us to continue to provide not just the core and functional services of a health department, but the required services, especially those in immunization, communicable disease, our sexually transmitted disease clinic, our environmental health programs that cover everything from food protection to inspection and approval of wells and septic systems and other water quality programs we do in Macomb County. And also the services that we do in health education, health promotion, and the work in our medical examiner's office. With the budget that was presented, as Steve mentioned, we have a request for 2 part-time vision and hearing technicians. These are positions that are roughly going to be about $36,000, funded by additional money we're going to get from the state in October of this year. So we'll get funds from the state. They'll support these positions. They're part-time. They will focus on something we've been trying to do, which is increase the number of screenings for vision and hearing we do with the 3 to 5-year-old population. Something that the state has recommended that health departments try to increase the ability to do that, and not just in the regular K through 12 screenings. So we want to focus those 2 people on the preschools, the daycares. We're already doing a good job in the Head Start program with vision and hearing, and we want to increase the capacity, and that's what those 2 staff will be focused on. They're part-time positions, and again, those are grant funded. The other position is in our communicable disease program for a public health nurse. As you're aware, we have an opiate problem here in Macomb County and a heroin problem. And as a result, we have not just seen increased deaths in our medical examiner's office, but we've seen a significant increase in hepatitis C. Hepatitis C is a liver disease caused by the hepatitis C virus, can lead to chronic liver problems. We've seen in the last 6-7 years a 10-fold increase in the population, the 18 to 30-year-old population, getting hepatitis C. A lot of it is due to the transmission of the virus through blood. And needle sharing and the paraphernalia used for injection, this is causing hepatitis C to really increase. We piloted a program maybe a year and a half ago to 2 years ago with a grant we received to really enhance our surveillance, case finding, care coordination, getting people linked to services, and also trying to prevent this within the younger population. We believe these numbers are at a public health crisis in Macomb County for hepatitis C. So putting a nurse in place in our communicable disease program is a high priority for us to address this problem, to work with community partners for education, increased surveillance, follow-up, case management, and again, the prevention of hepatitis C, which we think our pilot program showed promising signs, and we want to fund this position, as Steve said. Some increased revenues that the department is generating will help support that position. So with that, again, we're satisfied with the budget recommendation. And before I go to questions, I'd like to have Dr. Spitz come up here and just make a few points about the medical examiner's office.
Very good. Thank you. Doctor?
Thank you. Thank you very much for having me come discuss the medical examiner's office with you. I know most of you, but have not met all of you. My name is Dr. Daniel Spitz, and I serve as the Chief Medical Examiner for the county. We are very satisfied at the medical examiner's office with the budget that was submitted by the Office of the County Executive. This budget will enable us to carry out our mandated duties in regards to death investigations and certifications. We very much appreciate the medical examiner investigator position that was approved by the board in 2017, and I'm glad to let you know that all of our positions, both full and part-time, are currently filled. The medical examiner's office has a budget of around $2 million, and in 2018 we expect that to increase by about $60,000. The increases are largely due to increases in operating expenses, and those include medical supplies, transportation services for decedents, laboratory services, toxicology services, and transcription services. Most of the increases are directly related to the increased drug-related deaths and what we've all heard of as the increase in opiate-related deaths.
Right.
You all have received a copy of our 2016 annual report. Some interesting and in some cases concerning facts regarding our caseload in 2016 are that our drug-related deaths increased 29% from 2015. Fentanyl, which really had not been a major problem in Macomb County when it was in some of the other neighboring counties back in 2011 and 12 and maybe even 13, increased significantly in 2016. The number of fentanyl-related deaths, which kind of broadly classified as synthetic opiate-related deaths, increased from 27 such cases in 2015 to 145 in 2016. Our suicides were down by 12%, but our accidents were up by 18%. I'd like to inform the board that in June of this year, we received our yearly review by our national accrediting body, and following that review, we were again reaccredited by the National Association of Medical Examiners.
Cool.
Our goals for 2018 will be to continue to conduct death investigations with the highest level of professionalism and compassion. We will continue to meet the numerous death investigation standards which are set forth by the National Association of Medical Examiners. Again, I'd like to thank the board for their continued support, and I'd be happy to answer any questions.
We have number one on the hit parade is Commissioner Chairman Smith.
Yes, sir.
Thank you. Dr. Spitz, Bill, thank you for coming. I'll give the same speech I gave to Ms. Powell, that we're probably going to have a few more questions after today just because this was just given to us, but thank you for coming. I have a question that you just mentioned that you received National Public Health Accreditation. Yeah. I thought you said you were going, that was on the long-term goal, so I must have missed something. Or is there different accreditations?
The medical examiner's office has a separate national accreditation.
All right.
Public health departments have separate national accreditation.
All right. Then for the health department, let me ask you a question. What does that require? Are we close to that? And how close, and what kind of benefits come to the department from having that accreditation?
Well, this is a national movement in public health departments, and I think that it really brings the accountability of a health department to continuously improve the health of a community. That's what population health, and that's what we're working on. I think it also, that accountability is there, the transparency there is there. And also, when you're nationally accredited, you are more competitive with getting grants also. Some of these national grants from CDC or Department of Health and Human Services. So I think the benefits are there. We are probably about a year, we expect sometime in 2019 to have an official visit. There are things we still need to do to prepare, because it's different than programmatic accreditation, which is what we get from the state health department. It's more functional. Communication plans, workforce development, leadership, meeting core competencies, how are staff meeting core competencies, and on and on. How are we effectively addressing communicable disease investigation and related to foodborne or diseases, and how we are doing that work. And I think that it's more comprehensive, and again, continuous quality improvement and accountability, I think, are benefits that we grow and strengthen as a local health department.
Great. And just if you have these numbers, like out of all of the health departments nationwide, what percentage of them are actually nationally certified or nationally accredited?
There are probably around, I'm going to say, 2,500 health departments in the country. National accreditation, the first ones were in 2014, so that's when the accreditation process began.
Okay, so it's relatively new. Sure.
It is new. In Michigan, I believe of the 45 health departments, 5 health departments are accredited. Of course, they started this process right at the beginning. Right. So we're still early into it, but we have a lot of the indicators met. So
great.
Again, our goal is to have a site review.
Anything we can do to help? Anything we can do to help, as long as it doesn't take money.
You know, there's always a fee to be accredited.
So I have a question for you on page C40, at least on my screen. It shows the increase in staff for the managers and supervisors under the position type in administration. Mm-hmm. But when you drop down to the PHS administration, all of a sudden, manager, supervisor, professional support, clerical staff, all of a sudden 18 and throughout there's zeros or dashes. I'm guessing that's zero. What does that represent? Do we change some people over to a different? I'm not real familiar with why that dropped, and all of a sudden, and also the manager to supervisor went from 1 to 0 under clinical health services. So I'm just wondering what those changes represent.
Sure. We took we have 3 division directors. 1 in environmental health, 1 in clinical services, and 1 was in public health service administration. We moved the division directors into administration, and we moved the other positions also. So we closed out the public health service administration, that small cost center, which was basically where staff, there were no other real costs in that area. We moved them into administration. That's why you see we shuffled some people. So no change in the numbers of managers or supervisors.
Okay.
Okay.
So at the end of the day, we're kind of taking from this section and adding to that section. So
Correct.
How many actual brand new positions are we looking at?
No, these are not. These are just moving someone that's in that position already. These are not new positions.
Got it. All right. Good. Thank you.
Thank you. Next, we've got Commissioner Lucido.
Hi, thank you. I just had a question about is the family nurse partnership, is that different than the maternal child health services?
Yes, that's different.
Okay, the one that you were talking about that was recently implemented, that's the mother-child, or the infant, or through pregnancy, right? They're
Right.
From early pregnancy through 2 years old.
Correct, and that is supported through our general fund budget, the Nurse
Okay.
Family Partnership. The maternal and child health is in the general fund, but we also get grant dollars for maternal and child health
What's the
services.
difference between the two? The maternal and
I think it's just names. I mean, it's all maternal and child health.
but does the maternal and child health go maybe later than 2 years old?
Well, our maternal and child health resources are dedicated a lot towards our public health nurses that provide services to infants, especially the early on program,
Okay.
which is another program for evaluating children and doing case management with those that may have some developmental delays or other signs of learning disabilities at an early age. We also do our program in case management for children with lead poisoning in our maternal and child health program.
I'm just looking because I know that those programs are usually free with Medicaid. So when I'm looking at the budget and it's, almost $2 million for the maternal child health care service and I think it's $422 for the family nurse, is that the cost of salary wages?
The majority of our budget in a lot of these programs is for staffing.
Okay.
So yes, the maternal and child health, and a lot of those services too, if we can bill Medicaid or other commercial insurances, we have the mechanisms to do the billing too.
Okay. Because I know usually they're free if you
But
are,
again,
if you are on Medicaid.
But we will bill the managed care plan.
Sure. And do you
And-
provide social workers? I know you had talked about nurses.
We have one social worker, public health social worker on our budget, and she's supporting our maternal and child health programs.
Okay, great, thank you.
Thank you, Commissioner. Commissioner Drollet.
Thank you, Mr. Chair. You mentioned at one point that we were looking at hiring an additional nurse to help address the opioid epidemic. Is that accurate?
The hepatitis C, which is a consequence
Oh, a consequence
of the opiate problem that we're seeing in Macomb County.
Okay, so there'd be an individual hired specifically for that task. And how would we be? What ways would she be working to address that? To address that situation.
Well, as I said, about 1.5 years, 2 years ago, we had a pilot initiative where we brought in a part-time nurse through a small grant
Okay.
to do further surveillance and enhanced surveillance with individuals, especially the 18 to 30-year-olds who had hepatitis C, to see are they getting treatment. Are there people that they know in contacts that they might know, have they been tested? So we actually did enhance testing as a result of this too. It's within a couple of our programs. The nurse is going to be involved in some case management, referrals, public education, getting out to partners in the community that interact with some of those individuals with risky behaviors to help them get tested and get treatment, because there is treatment for hepatitis C also.
So the pilot program showed that there was effectiveness in this.
Correct.
And how would you characterize the most effective thing that resulted as a result of the pilot program? I mean, did rates drop? Did infection rates drop? What was the biggest change?
I think the two big outcomes, and maybe Dr. Lockhart might want to comment too. I think number one is the ability that we did identify individuals who didn't even know they had hepatitis C.
Okay.
And again, by identifying them and getting them into treatment and then making sure they knew they were hepatitis C positive, I mean, that's an important thing to know as far as secondary transmission. And I think the other thing is getting people into treatment who had hepatitis C. So those, I think, two of the important outcomes. I think the other thing, too, is this nurse is going to do other things, too. This nurse, we have seen recently, and you may have picked it up in the newspapers, we've had an hepatitis A increase in Southeast Michigan. Now, hepatitis A is more related to either food or unsanitary conditions. And we're seeing this problem amongst, again, the substance abuse user. I think about half the cases are substance abuse users. It's not just Macomb, it's in Southeast Michigan. We've seen numbers go up. It's not the first time we've seen the numbers go up in hepatitis A. But again, this nurse can be very supportive in those cases too, because we need to build capacity in our infectious disease and communicable disease program. We have 3 nurses there right now. Having a 4th can add value and capacity of our work in communicable disease. Kevin, I don't know if you want to add on to any of that? Okay.
Thank you.
Okay. Thank you, Commissioner. Next, we have Commissioner Myjack.
Thank you, gentlemen, for coming here today. I'm just curious, can you explain to me a little bit more detail what exactly is fentanyl? How is that produced? How do they die from that? What do people use that with? I've read a little bit about it, but not enough.
Fentanyl that we're all probably aware of is a prescription drug that typically comes in a patch form that is used for chronic pain patients and typically cancer patients who are in their fight and having severe pain as a result of their cancer. That is really not the same. We do see that, and we see that fentanyl being abused, but the problem that we're having is synthetic fentanyl. This is fentanyl that is created in these clandestine type labs in China and other places, and it's coming into this country and it's getting filtered into the heroin population, so that when a heroin user is buying heroin, they think they are buying heroin. They're familiar with what they have used in the past, but unfortunately now they are either getting a mixture of heroin and fentanyl, or in some cases just fentanyl by itself. Fentanyl is much more potent than heroin, and so you can see the problem when that gets into the heroin population. The other problem we're seeing is that little changes to the chemical compound of fentanyl makes all these different synthetic opiates Acetyl fentanyl is one of them. Carfentanil is another one. Carfentanil has been used as an elephant tranquilizer years ago. So, and there's many other ones, and the labs are constantly changing their process to try to keep up to identify new ones that are being made and then entering into the drug population. So, these drugs, fentanyl is very much more potent than heroin, and the synthetic or analogs that we call them are much more potent than fentanyl. So some of these things are hundreds of times more potent than heroin. So that's the big problem, is to deal with the deaths that are coming from these designer or synthetic.
So would you say
opiates.
fentanyl coming into Macomb County or Michigan is being imported here, or do they have labs
No,
around here?
I think it is being imported here,
Huh.
and there are certainly, the DEA is tracking the trends. The Midwest is a big problem. The South is a big problem. Out West, it is much less of a problem. Now, whether things are
Really?
heading that way, I don't really know. But the Midwest, Ohio, Indiana, Michigan, huge problems. It is putting a strain on a lot of offices, and including Macomb County, because one of the reasons why is because we order a laboratory test on individuals, on decedents that we do an investigation on. The problem is to pick up these designer opiates, it is a whole different type of testing. So not only are we ordering the regular test, but then we have to order a much more expensive test. And when your caseload is going from 20 to 150, and you're adding $300 or $400 to each one of those to do the testing to identify what we have, you can see how that puts a strain on our budget that has been allotted for our toxicology testing.
Wow.
It's very important to identify these so that the health department knows, so that the police departments know, to try to understand how these things are coming in, who's using them, who's distributing them, and so it is.
It's not going away anytime soon.
I don't see it going away. 2017 is adding on to 2016, yes.
Okay, let me ask you another question. So when someone dies here, prescription medication deaths, someone dies, do you guys look at who's prescribing the medication to the patient or user? And is there a contact between your office or the police and the doctor's office to say this person died from your prescription?
Well,
You know, why isn't that looked at more? I don't understand how in society that is allowed, that's not cracked down more. I don't understand. The pharmaceutical industry in general.
Well, the medical
Dr. Spitz, can you speak into the mic, please?
Sure. The medical
Thank you.
examiner's office obviously has no role
Right.
in law enforcement per
Right.
se. We do look at where these drugs are coming from, and we do have meetings with the DEA. Local law enforcement really isn't getting involved with prescription medications. They are involved in illegal drugs, heroin, cocaine, and all the different types of illegal drugs. But it's much more complicated to try to deal with physicians who are inappropriately prescribing medications. Patients are doctor shopping, so some doctors don't know what the other ones are prescribing. They're buying them on the streets, so it's oftentimes difficult to deal with this, but the DEA is well aware, and we do meet with them, and we share information, and what they do with it. You know, I can't say I always know the outcome, but I do know that doctors are being charged and are being tried for inappropriate prescribing practices.
Okay, last question. So after you perform these autopsies of fentanyl and prescription drugs and heroin, when you meet with the family members, what's a typical story of all these deaths that you hear? What do you think? What is
Well,
your world like as a doctor to think, gosh, this is terrible that this is happening. I'm doing my job. What could I be doing better? Or what does society need to do better to prevent more of the things you see?
Well, unfortunately, when it comes to my involvement, it's, for lack of a better word, too late. But the information that we can provide can help. And the story that we're seeing across the board is that these are people who originally get prescribed prescription medications for what is supposed to be a short-term fix for chronic pain and injury and illness, what have you. Unfortunately, that progresses to becoming dependent, and then the doctor shopping occurs, and that becomes difficult, and then buying the medications on the street, and that becomes very expensive, and ultimately that leads to heroin use. Heroin is much cheaper than buying hydrocodone and oxycodone on the street. And so heroin becomes the next course, and then heroin, as you know, and as I just indicated, leads to using knowingly or unknowingly fentanyl and the various fentanyl derivatives. And that has a very bad outcome. So where do you intervene? Well, I think society is intervening. I think physicians are intervening. It started 20 years ago when pain was indicated as the 5th vital sign. And when pain was a vital sign, doctors started, it was said that doctors were not addressing pain problems, and they addressed it, in my opinion, and a lot of people's opinions, a little bit too readily. Instead of using ibuprofen, people were giving hydrocodone and oxycodone. Those are very potent narcotics. And so now it's swinging back the other way, where pain management is being addressed. And unfortunately, it takes years and years and years to change doctors' habits, to change patients' expectations, and to deal with this problem. People still have pain, but it's the way in which physicians are going to deal with it that are going to start the process to change this.
Thank you. Thanks for coming here today.
Thank you very much. Commissioner Kleinfeld.
Thank you. When an individual ODs and it's an opioid that is not, and it's not heroin.
Will you turn your mic on, please?
I'm sorry, I need somebody to help me learn the system too. Are the local police called on those cases? You said they don't really get involved in the investigation. Whenever there's an OD death, are they brought in and called before it gets to you?
Any death that doesn't occur in a hospital, the police are made aware of it before we are. In fact, the police are the ones who contact the medical examiner's office, and then we send our investigator to the scene. So the police are doing an investigation at the scene prior to the arrival of the medical examiner. If it's a prescription drug-related death, yeah, the local law enforcement are not going to doctors' offices to deal with that. That really falls under a federal issue, and it becomes the DEA's process.
Do you know if they're asking to see the prescription and determining if the prescription's in the name of the individual that's died as opposed to a family member?
If it's at the scene, we collect all medications. We don't always know what the individual is using at the time. And that becomes very difficult, because now you have a prescription that's maybe given to a mother or a father, and the 20-year-old or the 18-year-old or the 15-year-old son or daughter is getting into that medication knowingly or unknowingly to the parent. You can see
I'm
the
just
problem
asking
with
because I actually personally know a child that died whose parent had a prescription and they didn't, and I just don't know if there's any ramification for that. And this wasn't somebody that was like a heroin addict. It was the individual was an athlete, so may have started taking it for some, an ankle or something like that. Sure. But they didn't have a prescription. The parent did, and I just wondered are there cases where individuals in the household are being held accountable when that happens?
It's probably a better question for law enforcement. My experience is that it becomes very difficult to prosecute those cases.
Okay, and with regard to I'm just curious, I think I have one more question for you, but I'm really curious how you use enhanced monitoring to identify individuals who did not know they had hepatitis C. How are you doing enhanced monitoring?
Well, I'm not sure if the word is enhanced. Maybe what we're doing is increasing testing. And we're increasing testing in our STD clinic, our family planning program, and we've actually identified individuals who didn't know they were hepatitis C positive from the testing we've done in those programs.
Is that because they're coming in requesting a different type of testing, and while they're there you say we should test for this, or as opposed to them requesting it?
They may be coming in with an STD, which is evaluated, but we will also do ask them if they would want a HIV test as well as hepatitis C.
Okay, all right, thank you. And then with respect to it swinging the other way, it might be swinging a little too far the other way in a lot of situations. There are a lot of people having major surgeries that can't get, I had a major surgery last year, and I got 3 days. And I had drainage tubes in my body for 10 days, and I want to tell you, I could have killed somebody. And it was over this. So I'm hearing other people now that there are hospitals, I don't know if there's a state law, but there are hospitals that are taking this philosophy on, that it's 3 days, and some surgeries are pretty significant. So I think there's a balancing act. You don't do it every time somebody breaks an ankle, but if they have a significant surgery, maybe, you know.
Well, I think you need, again, that's not the medicine I practice, but that's an individual thing for individual patients, and physicians are having a tough time balancing that.
Yes.
Okay,
Thank you.
Commissioners, if we can stick to budget issues, that I'd appreciate it. We've all got our aches and pains, and that comes with getting older. But the last person we want to see is Dr. Spitz. That being said, Commissioner Sauger.
Yeah, Doctor, just wondering, is there any drive-in businesses like we have in Dearborn where they just about drive in for their pills and nothing's said for how long that doctor finally got nailed over there for all the pills he put out? Do we have any of those type of businesses going on, to your knowledge, in Macomb County?
The only way I can address that is to say that I'm not aware of any drive-in places. Are there physicians in Macomb County that are common names in the individuals that we see? There are, and believe me, they are.
Romano, you started.
Appropriate authorities.
Okay.
Sometimes it takes years and years and years to follow these people and to monitor their prescriptions before the government then takes action. And there's a lot of that going on in the county right now.
Okay, in regards to the question asked about when we used to go on overdoses, we just get every pill we can in the house, make a report on it, take it to the hospital where we went, and then turn it over to the prosecutor. It's not up to the police agency to do anything on that, till the prosecutor steps in, unless things have changed. Okay?
When we go to a scene and there's a decedent there, the medical examiner's office collects every pill bottle that we can find. And they come into the office, every pill is counted, there's a log that's generated, and then once we get the toxicology report, there's some general assessment made between what the individual died of and what medications are present. Again, what law enforcement is doing with that information, I can't always answer that.
From prior experience, your dad was an expert on that. Okay, thank you.
Thank you.
Thank you. Commissioner Smith.
Thank you. And Dr. Spitz, thanks for giving us a little leeway and going into some of these topics. It's very interesting. Obviously, it's on the top of a lot of people's minds with all these drug deaths, so I appreciate it. As far as all the autopsies and the costs and all the testing, is there a recovery method? And I apologize for not knowing this. How much do we recover from families when we have to do autopsies and when we're doing these new tests? Do we try to recover from the families, or is this, how does that work?
There's no method in place for any recovery of any funds. This is a mandated process that is required to do death investigations and to have a county medical examiner and to do these investigations. The office does generate some funds through the use of cremation permits and through our reports that we generate. We do charge for those when they're requested. Cremation permits are by far the biggest source of revenue. There's several thousand cremations that occur within the county, and we do charge around $80 per cremation permit. And then there's a couple of other small sources of revenue, but that's really about it.
Okay, so I understand the ones that are mandated, right, because there's a death, we don't know what happened, but don't some families request an autopsy on some things where normally you might not do them? Is that something that's chargeable for? I'm just trying to see if that's even an option. I don't, just.
We don't really, we certainly discuss with families. We don't ignore their issues and their wants and needs, but that does not dictate whether we do an autopsy or not. We use pretty strict guidelines that are, in the state law that indicates which cases need to be investigated by the medical examiner's office. It said if it's a case that is not a medical examiner's case and the family wants an autopsy, then, you know, they're free to go about it in their own process.
Okay, and just, you know, and it's a little different, but I mean, fire departments, ambulance companies, I mean, they're starting to, in certain areas, you know, charge for services that were covered by, you know, the fact that they're, you know, getting paid by tax dollars to do that job, but they're finding ways around, not around, but I mean to actually charge for some of those services, even though they are still a taxed, you know, a public entity. So I don't know if that's even a possibility or something that any.
Something to think about, but it would be tough to send the bills to.
I understand that it's not, everybody wouldn't be billable, but I'm just a thought. I didn't know if we did anything like that or not.
Yeah, one thing, the state of Michigan formed a group to look at the medical examiner's offices around the state, because we know there are some different practices in different counties. And both Dr. Spitz and Patty have been part of that process. There was a report probably, I don't know, 6 months ago, and there's supposed to be continue to look at ways to do some standardization and to make some improvements so that we have some consistency across medical examiners. And I know that process has begun in Michigan. I'm not sure if it has anything to do with billing in there, but again, it's trying to get some common standard practices within.
It's really about standard practice as opposed to any types of revenue generating.
Right.
There's a big variation in what's going on across Michigan. Many counties don't have forensic pathologists in their area. They have a local physician who's not a pathologist and not trained in death investigation to determine which cases are being autopsied and which cases are not. So you can see there is a pretty broad range of what cases are being investigated. Down here in southeast Michigan, where Macomb, Oakland, Wayne, and some of the other larger counties, Kent County, those counties more or less are doing similar types of death investigations.
Okay, thank you.
Thank you. Couple of questions. You said that we're sending toxicology reports and so on and so forth to labs. Are these labs in local or out of state or where?
No, the lab that we use is called National Medical Services in Philadelphia.
Would it behoove us to look into setting up our own lab in this area? Do you think?
Well, I can tell you that Oakland County used to have their own lab, Wayne County used to have their own lab. They've all gotten away from them because the cost of having your own lab is significantly higher. I can tell you, if Macomb County set up its own lab, it would cost in excess of $1 million a year to run that.
Really?
Because the testing equipment is very expensive. It has to change frequently to keep up with the changing drugs, and then of course you'd need to have a toxicologist and a toxicology staff to run that and to manage the process. So, you know, what we pay is pretty small, and even the large offices are going toward outsourcing that because of the cost just being out of control.
All right. How about the facility you have now was new, what, 15 years ago?
2007.
Okay, 10 years ago. Are we going to need to do some renovations at the coroner's office soon?
We have put forth some plans, and Bill would know how this whole process works better than I, but we have put forth some plans, and we've had some meetings to address some security issues. I can tell you back in 2007, during the process of building this office, there was not one mention of security. And you can imagine that over the last 10 years, security, not just at medical examiners' offices, but across the board, have become a little bit more important. We do have a little bit of a space issue when it comes to our office space. So we're trying to address both the security concerns as well as the space limitations by doing and proposing a renovation. Our autopsy suite is not part of any type of change. It was built great in 2007, and there's nothing proposed to change that. The changes would involve some of the office areas as well as to address the back of the building where the drop-off and pickup of decedents takes place.
Right.
We're proposing enclosing that area with a garage that would allow for some significant security, and also address the just the exposure that's exists because it's in an outside area. It's not blocked off from the
All right.
general public.
All right, thank you very much. Commissioner Leonetti.
Thank you, Mr. Chair. Chairman Ridella, I have a question for you. Looking at the budget, conferences and training for 2016 were about 35,861. Are you looking at the same page I am? It's going to be under your general fund for the health department.
Okay.
And then it's looking like you're recommending 58,682 for the 2018 budget. Now, I think you said something in 2019 we're expected to have a national review of our department. Is that correct? Mm-hmm. Okay. Is that going to be enough for you for all the different things that we have to do to look good on a national level? You were saying we'll be accredited nationally in 2019. Those conferences and trainings that you've proposed for 2018, is that, I presume, what you're going to need to look good in 2019?
Yeah, I think that the funding there, again, one of the drops in our recommended for the 18 year is because we did the training for the nurse-family partnership this year, because some of those trainings
right.
were a little more expensive.
That's why it went from
that
77 to 58. I get
right,
that.
That's
okay.
why that went down.
Okay.
And I believe that amount of funding in there is going to be appropriate for our workforce development plan.
Okay.
And the requests that our divisions submitted for this year.
And the only reason why I ask is because obviously we had to amend it in 2017 because of the nursing program. So, I'm just wondering if you discover, we could always amend, I suppose, but I'm just hoping that you're taking into consideration this plan to get nationally accredited for 2019 in your proposed budget for 2018.
I think that's an adequate amount.
Okay. All right. Thank you. All right. Thank you, Mr. Chair.
Thank you. Do we have a motion to receive and file? We have a motion by Brulette, support by Sauger. Can you please vote?
Thank you.
Thank you, gentlemen.